Join us August 21st for this month's Lunch and Learn with the Link, focusing on chronic GVHD of the skin. Our guests will be Dr. Rachel Rosenstein of the Hackensack Meridian School of Medicine and Ann Fitzpatrick, an MDS survivor. This free webinar will be Wednesday, August 21st at noon Eastern. To register, visit nbmtlink.org or follow the link in our show notes. Welcome to Season 14 of the Marrow Masters podcast, brought to you by the National Bone Marrow Transplant Link and sponsored by Insight and Syndax. The National Bone Marrow Transplant Link, established in 1992, strives to help patients, caregivers, and families cope with the psychosocial challenges of bone marrow and stem cell transplant, from diagnosis through survivorship. This season focuses on chronic graft-versus-host disease, or GVHD. We'll cover male and female sexuality, the emotional struggles of the disease, and even atypical presentations of GVHD from the perspectives of patients, caregivers, and medical professionals. Here's your host, Executive Director of the NBMT Link, Peggy Burkhardt.
Hello, everyone. We have a special episode today. With us is Dr. Tosin Goje of Cleveland Clinic. Dr. Goje is an Associate Professor of OBGYN and Reproductive Biology. Thank you for being with us.
Thank you for having me, Peggy. This is a very important topic, and I hope we're able to help our listeners.
Yes, this is not an easy subject. We're going to talk about female sexual health issues, and it is my hope that this podcast today will help people find the answers to some tough questions that they don't always feel comfortable asking, especially as these issues relate to graft-versus-host disease, GVHD. So let's get started. Dr. Goje, let's talk about female sexuality and genital chronic graft-versus-host disease.
Okay, so let's lay some foundation, okay? Sexual dysfunction is one of the most common consequences of women who have experienced one malignancy or the other. And when you now come down to bone marrow transplant and all the management that goes with it, I can inform our listeners that 80% of female survivors have no significant improvement to their sexual function 5 years post-transplant without intervention. They may feel better physically. The doctor might give them a good report, but they don't feel good when it comes to sexual health. And when I talk about 80%, that might not be the true prevalence because it's underdiagnosed, not recognized early, and patients might not talk about it.
Wow, that's quite a number. It's pretty grim. So let's break it down, and hopefully we can find a way to offer some hope and some guidance to our listeners. Dr. Goje, can you please explain why the issues with sexual dysfunction continue even after the physical and emotional well-being return to normal?
Yes, Peggy, it's multifactorial. Many factors contribute to sexual dysfunction, and let's unpack it a bit.
Okay.
We have the systemic chronic graft-versus-host disease that leads to tiredness, fatigue, change in body appearance, perception of not being attractive due to all the management which is needed but has its own consequences. Then we have chronic genital graft-versus-host disease, which we'll talk about in details in this conversation. Genital graft-versus-host disease changes the appearance of the genitalia, whether male or female, makes it less supple, makes it less lubricated. Then the third factor we want to discuss is libido. Medications are needed, but some of them actually will alter or decrease the libido of a patient. And finally, the overall psychosocial factor of being overwhelmed with a diagnosis, going through management, feeling self-conscious because of the changes of the skin and body, and sometimes depression.
Yes, we do hear this often. So can you define for us the female GVHD as it relates to the vulva and the vagina?
Absolutely. Most of the time, it's chronic GVHD that affects the genitalia. Changes seen in the vulva and vagina that many times are in three areas, either what we call sclerotic or thickening, planus or feeling raw and being on fire. And the third part is lack of estrogen or atrophy. So the changes could be all three, or it could be one of the three. And by affecting both the lips or the vulva, as our patients will call it, and the vagina, it makes lubrication almost impossible, causes pain with intimacy called dyspareunia, burning with urination, and sometimes bleeding on contact. I need to say at this point that these changes could happen as quickly as 7 to 10 months after the transplant has happened. And sometimes it could be gradual or it could be sudden. I have seen both, whereby patients gradually feel the changes in the anatomy, and we try to talk about it. But the most alarming are patients that have the sudden change, like within a month. And like January, I could have intercourse, and by February, it was impossible. So those are the ways genital graft-versus-host disease presents. The other thing we should mention so that patients don't feel alone is the incidence. I have gone through many studies. Although the studies have like 100 to 350 patients, one study found that 25% of patients that have had an allogenic transplant had graft-versus-host disease. 2 other studies found 35% and 46%. And we must remember that this is an under-recognized, underdiagnosed disorder. So even 25 to 46% as incidence could be underestimating it. So it's that prevalent in this population.
It must be so difficult because, here these wonderful people get through everything. They just want their lives back. And now this. How do you handle that as a doctor?
Because it's multifactorial, it has to be managed in a multidisciplinary method. Let's dial it back and talk about what does graft-versus-host disease do, first of all, to the patient, apart from the appearance. We said the signs and symptoms could be standalone. It could be intertwined with lack of estrogen. Now, I just want us to pack that to one side to say standalone. Patients that undergo bone marrow transplant, if they are young, they could have what we call premature ovarian insufficiency or premature ovarian failure, meaning the ovaries have stopped functioning. This has downstream effects on the genitalia, in addition to graft-versus-host disease. And if the patient is already menopausal or perimenopausal, it accelerates that. So based on these 3 approaches or 3 pathway to sexual dysfunction, we'll talk about what we call the signs and symptoms. So we have the dryness of the vagina, we have the itching of the vagina or pruritus, we have vaginal pain, vulvar burning, we have dyspareunia, which is the pain with intercourse or intimacy, and we have burning with urination. So to manage genital graft-versus-host disease, you have to manage all this. For patients that are menopausal or have premature ovarian failure or insufficiency, many of them are going to need hormone replacement, especially that 32-year-old who has a partner and we want her to continue living an active life. They will need hormone replacement therapy, which we can discuss with her oncologist to see which is the best approach for her, because her hormone replacement therapy will be based on if she still has a uterus or she does not have a uterus. For patients who have menopausal symptoms alone, which is just dyspareunia or pain with intercourse, they might benefit from vaginal estrogen alone or some moisturizers or lubricants over the counter. Now, for patients with graft-versus-host disease, which we're going to get to, they need other medications. So do you want me to discuss graft-versus-host disease at this point?
Absolutely.
Okay. Graft-versus-host disease has to be an individualized treatment, whether it's a standalone graft-versus-host disease or is intertwined with menopausal or premature ovarian insufficiency. Number 1 is talk about it.
Mm-hmm.
Talk about it. There are a lot of studies out there that shows that when providers don't ask the questions, patients don't feel obligated to bring it up. I take care of a lot of patients that have had bone marrow transplant, and I'm honored to do that. I call them my ninjas and my warriors. And I know that they just feel so grateful to be alive that They don't talk about things that are very important. And the fact that they don't talk about it does not mean it's not important to them. So as providers, as counselors, talk about it, ask the patient. If you don't have the capacity, there are validated questionnaires that providers can have in their offices and ask the patient to complete. A validated questionnaire or a tool that is completed in the privacy of the patient's house or in the waiting room can also help start the conversation. For patients with graft-versus-host disease, you need an immunosuppressant. Big word for just either steroids or other medications that help to reduce or stop inflammation. In the United States, the commonest immunosuppressant we use is topical clobetasol, which is a steroid.
Okay.
Patients request it or the provider gives it to them, and they apply it to those dry, hardened, itchy area. In addition to trying to stop the inflammatory process going on, we need to improve the vaginal health. Some patients can start with something as simple as a moisturizer over the counter or with a lubricant. But if those are not working, then they have to go ahead in collaboration with their oncologist to try vaginal hormones. It's important that listeners know there's a difference between a vaginal hormone and an oral or systemic hormone, because patients get very scared. I don't want to take hormones, Dr. Goje. I'm like, no, this is a topical vaginal hormone that you use once or twice a week to optimize vaginal health. It helps with lubrication. It increases the collagen of the vaginal area so that there's no bleeding with activity. Some patients might need a dilator because if graft-versus-host disease has been going on for a long period of time without any remediation, because I talked about sclerosis or hardening, the vagina gets hardened and gets almost closed up, called stenosis. So patients might need a dilator, which they get from any store over the counter. I always recommend silicone. Silicone dilators are more gentle and they can be gradiated. They start from the smallest diameter to the biggest, and they go in the privacy of their house, coating it with a lubricant or with their steroid, and dilate gently to keep the vagina patent. And slowly they can resume sexual intercourse. Some patients, we need more than a dilator. I've had a few patients that needed surgical intervention.
Wow.
Over a period of time, 10 years of not, actively managing that area and not being sexually active, there's almost like a closure. So they might need surgery. And then after the surgical intervention, they continue with the dilators and the vaginal creams. And finally, we have the laser, the Mona Lisa, as it's called. It's not the panacea for everything, but when patients have tried surgery or they're not candidates for topical creams or they cannot use vaginal hormones, some providers might reach out to experts to try the laser therapy for patients.
And do you find that is successful, that therapy?
It's not as successful as if you had surgery and then continue to use your dilators and your topical steroids and vaginal hormone. But we're here to make sure patients know that they have options.
Mm-hmm.
Some patients might not want to use a vaginal hormone, even when I explain that it's safe.
Okay.
And I want them to feel better. So I offer them options to consider.
I think that's wonderful. And I would imagine the laser is less invasive than the surgery.
Correct. It is less invasive. Usually it's 3 sessions in your provider's office or the expert's office.
And most providers can do that right at their office?
Correct. Those who have the certification right to use the laser, correct.
All right. Maybe in the show notes, I'd love to include a little more information about this so that people know that these are viable options. This is great. Thank you so much for sharing this.
You're welcome.
Dr. Goje, let's talk about communication. I know you touched on it. What providers and patients need to know to feel more comfortable. Maybe even the younger providers. I'm sure it took you a minute to get to the point you are. And we just want everyone to feel more comfortable. And I think you are accomplishing that right now. Thank you.
Yeah. So communication is important. And I'm speaking to both the patient and the provider. I know some providers are not comfortable or they are not trained to ask the question in a respectful manner. And using validated questionnaires will help them. They just need to go online to look for vaginal, genital, sexual health questionnaires that they can electronically or physically hand over to the patient if they're not comfortable starting the conversation. Also, we need to empower our listeners to speak up.
Mm-hmm.
I've had cases where young patients came to me, 35, 40, saying, I would like to have a family. I would like to be intimate with my partner, but I can't because of pain. And we were able to handle that. Started this patient on oral hormone therapy, vaginal therapy, and she adopted a baby and is intimate with her partner. So that is a success story.
Yes.
So communication is important. And the providers should train themselves to also listen in a non-judgmental way. Ask questions about low sexual desires. Ask questions about low libido. Ask questions on vaginal pain, arousal, orgasm. Even if as a provider you don't know what to do, you can refer the patient if you actually get to the bottom of what the concerns are.
Okay. Tosin, what proactive actions can survivors address early in their treatment?
Number one, see a gynecologist before you start your treatment. Make sure you have appointments every year, regardless of if you have any complications or not, so that your providers have a baseline. If you have any concerns, reach out to your provider and tell them what your concerns are, and don't be blown off. Like sometimes patients feel no one listened. I'm like, try somebody else. And also review your medications with your providers. There are some medications that manage endocrinologic problems that decrease libido. There are medications that are used to manage mood disorders, mental disorders that can decrease your libido. And patients are taking these medications without knowing that they are benefiting from the medicine, but the side effect is affecting their relationship or their intimacy with their partners. So it's important they review their medicines. Also discuss what your provider thinks is healthy vaginal practice.
Okay.
For patients that have survived any malignancy or the other or graft-versus-host disease, I dissuade them from using over-the-counter medications without discussing it with their partners or with their providers. Some of these medications can lead to burning in the future, especially medications that have topical anesthetic agent in them. A patient might buy an over-the-counter topical anesthetic agent because she's burning, and continuous or overuse of that medication, I've seen it cause ulceration. Yes, it helped with the burning and the pain, but the side effect was not good at all. So if you're burning, I know it's a personal thing. You don't want to talk to a provider, so you just get an over-the-counter medicine. I'll say not to do that. Over-the-counter medications that patients buy should be just lubricants. When you're looking for lubricants that are either silicone-based or water-based, and there are many of them, like Replens is a good moisturizer. So Replens is a good moisturizer. There is, I think, Luvina, that is another good moisturizer. Replens has been in the market, and disclaimer, I don't have shares in Replens. I don't know the company. Just disclaimer right there, but Replens is a good moisturizer. Luvina is a good one. Sometimes patients can get a compounded moisturizer. I want to say here that the active ingredient in most of these moisturizers that are good is called hyaluronic acid, like the same one that is used for the face. It's the same idea. It retains moisture. So wherever you reside, just look at the active ingredient of the moisturizer. It should have like hyaluronic acid or silicone-based. Moisturizers are there to keep the vagina lubricated for a longer period of time. But if a patient does not want to use a moisturizer, they can go ahead and use a lubricant. Lubricants are like KY gel. They dry up easily, But those are ways to stay proactive for the vagina. And if the moisturizers and the lubricants are not helpful, then the patient should consider the vaginal hormones like the estrogen vaginal hormone or DHEA. I think one of the brand names is Prasteron, but many times I tell patients that these medications can be compounded cheaper as D as in David, H as in house, E as in Edward, A as in alpha. So they can research into this. So those are the proactive steps that patients can take to maintain a healthy sexual life.
This is such great information. People are going to really appreciate this. So, Tosin, what can couples do together to try to solve these issues?
Excellent question. Number one, communication. Couples have to communicate about this issue of sexual function and the lack thereof. Patients and couples, when they feel comfortable, can see a sex therapist. Sex therapists talk about many things. I will not go into details, but I want patients to know that, especially the conservative patient, it doesn't mean sex itself as the act, but more of talking about it, talking through it, and understanding what actually is the problem. We talked about vaginal pain. Some patients don't have a decrease in their libido. What they have is vaginal pain that leads to an aversion of intimacy. So a sex therapist can actually break this down to understand what is going on. Couples therapy is also important. It's different from sex therapy. Body image is an issue. Feeling unattractive is an issue, and couples therapy can help with that. Couples therapy comes with either behavioral therapy, role-playing between the couple, or even biofeedback. So it depends on where the patient wants to start from.
What was the last part about feedback? Can you explain that?
Biofeedback. So biofeedback is when a couple goes to therapy and each person is able to talk about the problems, and then they get a feedback of what they do to ameliorate that problem.
Terrific. Okay. Boy, I'm learning so much today. Let's talk about the younger women. You know, in addition to all of this, we've got young survivors that they're worried about their fertility, they're premenopausal. What do you have to say about all of that?
Young patients or survivors can be proactive, especially if they still want to have a family. There are options to freeze their eggs and then use the eggs themselves later or use a surrogate.
Okay.
But they have to have this discussion even before therapy starts.
You know, we did an episode several seasons ago. I had no idea. I'm just going to mention this because I think it's important. The resources available. There are so many wonderful foundations and organizations that want to help people, young women, young men, have their family. And I would like to include those again in the show notes because I don't think a lot of people realize the financial support that is out there for this endeavor.
Correct. Their financial support and insurance also covers it. That was my own aha moment when a patient said, I want to talk about egg freezing or ovarian preservation, as we call it, because my insurance will pay for that part of it. Some insurance might not pay for the in vitro fertilization itself, but for patients that have a medical indication, they will pay for ovarian preservation or the egg freezing. So patients need to have this discussion to know if there's a foundation that will cover it, or if their insurance will pay partially or the total amount.
Or maybe it's a combination of all of it, you know, to make that dream possible for so many young people. And I love what you said about the importance of discussing that in advance because it's worth it. It's important. So we covered a lot today, Dr. Goje. Is there anything else that you want to cover?
I just want us to know that some survivors don't have GVHD, but they still have sexual dysfunction.
Sure.
As we alluded to. So if you examine a patient and there are no clinical signs of GVHD, that doesn't mean everything is all right. You should still ask the question. Some patients just have atrophy from lack of estrogen.
Mm-hmm.
And yes, lack of estrogen is a natural part of aging, but it can be accelerated with bone marrow transplant. The other thing I want to mention is infection. Most patients that have gone through bone marrow transplant know that they are on a cocktail of antivirals, antifungals, antibiotics at some point for infectious disease control. The fact that I survive AML or CML does not mean I cannot have a vaginal infection. And that could be the trigger for sexual dysfunction. A patient that has an inflammatory infectious disease like yeast that incites a lot of burning, or trichomoniasis that incites a lot of burning, could still have sexual dysfunction. And early recognition that it's an infectious process and just giving the antibiotics or the antifungal is all they need. So we have to remember that. The other thing I want to talk about is called vulvodynia. Some patients over time will develop chronic vaginal pain, and what they will need is medications for chronic vaginal pain. Some of them are topical, like gabapentin. Some of them are oral, like gabapentin or Elavil. So we need to understand, we're talking about sexual dysfunction in this group. It may not be GVHD. It may be a chronic vaginal pain that has happened over the years. And if nothing works, they might need to go to a pain specialist for that. So I want us to get that total picture of so many things that could lead to sexual dysfunction in this group.
Oh, this is amazing. I do have a question for you. So someone is back home, they go to their OBGYN. Do you think most OBGYNs know the difference? Do you think that this is something they need to call their transplant center about, or try to work through it with their community OBGYN?
I think the community OBGYN should know what atrophy looks like, should know what yeast infection or trichomoniasis is by taking a swab and sending to the lab. But not all of them will recognize genital GVHD. That I'm certain of. Not all of them will recognize it, especially if they've seen just one or two during their training. If the anatomy of the patient doesn't make sense to them, or they've treated for infection and the patient is still symptomatic, they should not dismiss the symptoms, but refer the patient out to someone who has more training for this kind of conditions.
So really go with your gut feeling.
Correct.
If you just don't feel you're getting the answers that you need, and it's not your local doctor's fault, like you said, they just don't see a lot of this, and it's okay. The communication again, reach out to your transplant center, try to get the answers you need so that you can have the best possible life post-cancer.
Absolutely.
Well, it has been a pleasure. I just can't thank you enough. We're also going to be covering male sexuality in this season. And I think these two episodes are going to complement each other beautifully. And you are just a gem. And thank you for what you do for patients. It is so obvious how passionate you are about this topic. I'd imagine that it comes from your experience with so many different patients.
Absolutely. My patients are strong. As I said, I call them my ninja warriors. They go through a lot and they're still grateful for the care. But that's not enough. They are individuals that have families, goals, and needs. I remember a few years back, I had a patient with vaginal pain, a lot of sexual dysfunction. And to manage her expectations, I said, "What do you hope to achieve from all this treatment?" And she told me a story, which shows why I'm passionate about this. She said, "For 2 years, while I was going through my therapy, my husband stood by me. He was there all the way for me. And I just want to feel better, to be intimate again with my husband. I think this is my way of coming back to say thank you and being united with my husband again." Such selfless goals again. And I think not everyone gets to hear this from patients, but this is why we do what we do, so that our patients feel empowered that whatever they need is legitimate and we should work with them to get them over every hump.
Wow. Well, thank you very much for that. That's an incredible story. Your heart and soul, we can just tell that you care so much.
Yes. They've gone through a lot, and I believe that their health holistically should be prioritized and optimized, not just the bone marrow.
Yes. Thank you so much.
Thank you for having me.
This has been the Marrow Masters Podcast. If you know someone who would benefit from the information in our show, please share this episode with them. And don't miss future episodes of our show. Follow Marrow Masters for free on Apple Podcasts, Spotify, YouTube, or wherever you're listening right now. And to connect with the National Bone Marrow Transplant Link, visit nbmtlink.org or tap the link in our show notes.